Well, good evening and welcome to the meeting. So this is the meeting of the Edinburgh COVID Committee, and we have a series of meetings almost every week, and this week is on testing. So welcome to the meeting. Just a few things before we start. First thing is we'd like to, if it's possible, to record the meeting. And if you want to speak but don't want to be recorded, if you could just let us know in chat or anything like that. It's just so because a number of people have said that if they can't get along, they'd like to be able to hear. And I'm sure they'll want to hear tonight's meeting. So is that okay with everyone? Is there no problem with that? Okay, good. So that's the first thing. Thank you for that. Second thing is, well, we've got three speakers who I'll introduce in a moment. But if you want to speak after they've spoken, use, if you're familiar with this, use the participants button, click on that and raise your hand, because with a large meeting like this, it's the only way to really manage it. So, but I'll remind you when we get to that point. So that'll be the speaking. And in terms of the speakers, I'm pleased to introduce three speakers. First one we're going to hear from is Heather Gilfillan, who's a Unite rep, and she works in Laboratories in Edinburgh. The second one is Jonathan Flaxman, and we're very pleased to have him because he stepped in when Jackie Applebee discovered that she couldn't get her Wi-Fi going. So at the last minute, Jonathan stepped in. So we're very pleased to have him. And I'll introduce him when we get to him. And then finally, we've got Linda Brown, who's going to be speaking from the point of view of a service user, in the sense, somebody who uses the service of the testing at the end. And I'll introduce her when we get there. So first of all, we'll have Heather, who, as I said, is a Unite rep in Laboratories. And Heather, if you want to unmute yourself, you're already great.
Good evening.
Go ahead, thanks.
Good evening, everybody. As Donnie said, I work in the laboratories in Lothian, and I'm employed as a biomedical scientific support worker. I'm also a union workplace rep and a health and safety rep. Now, at the start of the pandemic, the NHS labs were really busy, extremely busy. But then, all of a sudden, the new Lighthouse Laboratories came on scene, and NHS labs became quieter. Not only did they lose COVID samples, but they also lost the routine work that is the bread and butter of NHS labs due to hospitals, clinics, GP practices. The workload went down 75% on average across all the laboratories. As the pandemic went on, more and more bad news stories were coming out about the Lighthouse Laboratories, and things began to change, but the NHS was still ready, primed, willing to go. Staff were there, testing kits were available, but there was just no samples coming in. If you were to go on social media at the moment and you search NHS test and trace, what you would find is post after post from people saying, please remove NHS from the title, because it just doesn't work. And the NHS is being blamed for something that it's nothing to do with us. It's private companies that are taking billions and billions of pounds of private money, public money, and they're just making a complete failure of the test and trace. Years of outsourcing and privatisation of commercial labs in England has just made things chaotic. The scene in England is terrible. It's not so good in Scotland, but it's a lot better. Serco, the company that runs the test and trace system, has already exceeded its predicted profits for the year by over £30 million. And that's all thanks to the COVID-related work and extensions to government contracts. The system has been highly criticised for being less than effective, and it would really benefit from being run by local health protection teams. And the new lighthouse laboratories, they've also been highly criticised lately. They had health and safety failings. They were criticised for lack of suitable PPE, overcrowding, poor safety protocols. Some staff say they were traumatised and freaked out. Staff were employed with limited lab experience, no proper safety inductions took place, and working practices were chaotic and dangerous. Although the lighthouse labs have been investigated by the Health and Safety Executive, no improvement notices were ever served on them. The Health and Safety found that they had poor working conditions, inadequate safety training, and lots of other health and safety failings. Working in a lighthouse laboratory has been described as being similar to working in a factory and on a production line. And due to expanding demand, the NHS in Scotland will now be setting up 3 regional testing hubs, one in the West Coast, one in the East Coast, and one in the North. These labs will be governed and run by the NHS. Regulations and quality control will be at the heart of the running of them, and the staff will be employed with equal terms and conditions of that of staff already employed in the NHS. Laboratory medicine staff will be fully trained, qualified, and accredited, and they will deliver an excellent service, one that honestly should have been used from the very start. The First Minister announced yesterday that 1/7 of the Scottish population had already been tested for coronavirus, and also that due to the Glasgow Lighthouse Lab possibly being overwhelmed, that samples were sent to other lighthouse facilities across the UK. This resulted in delays in the results yet again. Alan Wilson, who is the chair of the Biomedical Institute for Science based in Monkland Hospital, North Lanarkshire, recently said that the problem with the lighthouse labs are that nobody understands how they operate. There is a lack of transparency to what happens in the lab because it isn't a part of the NHS testing. It is delivered through the UK government. It is difficult to find out what the issues are until they actually hit problems like they just hit the weekend. They work as a network, so samples are moved around the country quite often. If there are any problems, that in itself causes turnaround delays, and also had an issue with staff returning to academic institutions when the universities started back. We know they are actively recruiting at the moment, but honestly, who in healthcare science wants to work in a factory? NHS laboratories are calling for more transparency. If the lighthouse labs work more in collaboration with NHS labs, we would be able to work between the two more easily and focus on the samples and the results that are needed more quickly, urgently. Scotland itself has taken a slightly different approach to test and protect, favouring a boots on the ground approach. This is where if a cluster is detected, local NHS health protection teams take charge. Having the benefit of local knowledge is the key to breaking the spread. The basic principles of test and protect is person, place, time. Local teams with local knowledge doing detective work. Where has the case been? Who have they been in contact with? This all brings a picture. Where's the transmission started? Looking at ventilation, toilet facilities, communal areas, all help the team decide whether a workplace can remain open or have to close for isolation. They also look at the age group of cases. Due to younger people are more likely to travel further afield and spread more easily. Questions that you're usually asked from Test and Protect in Scotland are your name, postcode, date of birth, places you've visited, people you've been in contact with, anywhere you've been within a 10-day period, and also within 48 hours before any symptoms started. And now we're in the second wave of COVID-19, it's more important than ever that we start getting this right. Already we've seen universities hit with high cases of COVID. We are seeing a rise in high school pupils testing positive. Hospitals are starting to see a rise in COVID patients. West Lothian itself has been hit extremely hard, with yet another 2 nursing homes being hit with COVID. The hospital at St John's is reaching overcrowding with COVID patients. Currently, we're at 3 wards that are now full of COVID. Scotland's National Testing Project Centre is at the start of the system, liaising with NHS 24 and checking with travellers on return. It is urgent now that people listen to the advice for self-isolating, for quarantine when they return. If you're contacted, please do as you're told. The wave this time is higher now than it was the first time, and labs will be inundated. Across the UK will be inundated with tests, and we really need to get the system right and get the testing right for everybody. We need to stop the control of this and control the spread of this virus. And until we get a vaccine, until there is a vaccine available, and we just hope that everybody stays safe and everybody was careful. And that's really my part.
Thank you so much, Heather. That was great. Very, very interesting. Thanks a lot. Okay, thank you. So we'll move on now to our next speaker, who is Jonathan Flaxman. He's a retired GP working with NHS 111 COVID Clinical Assessment Service. He's one of the doctors in Unite, and he's also on the executive of the Brent Trades Council in London. So, Jonathan, you've got similar sort of amount of time, about 10 minutes or so. So, and Jonathan's going to put up some slides, so the screen will disappear as they're shared. So, go ahead, Jonathan.
Thanks very much, Donny, and thank you for inviting us, and it's a pleasure to see you all. Last time I was in Scotland was as a medical student at the Glasgow Royal Infirmary a very long time ago. So it's nice to be back. And thank you, Heather. I thought that was great. It was really good to have an insight into what's going on in the labs. And I know from some posts on Twitter from people I follow that things are not so good in these lighthouse labs with standards and things like that. Okay, so I've got some slides to show you. If you'll just bear with me. I'm just going to get to the beginning. Great, can you all see that? Okay, so I'm just going to talk a little bit about airborne transmission before getting on to testing, because I think it's a very important topic, and I think it's key to actually tackling this pandemic. So there is the terrible virus in all its glory. It's an amazing picture done with electron microscopes. And what you can see there is the receptor of the virus, or the virus attaching to the ACE2 receptor in a cell wall. And that's the key to how the virus gets into cells in the body. Beautiful, but terrible, of course. So the 4 routes of transmission of COVID are there for you. Basically, large droplets. So those are the things when we sneeze and cough. The aerosols, which are really key, which are microscopic, you can't see them, they travel through the air. Direct contact when we touch each other. And then the virus being deposited on surfaces, anything from clothing to floors to countertops. And then you touch them, and then you touch your face, particularly your eyes, nose, or mouth. COVID's an indoor disease. It's really important to remember that. Outdoors is pretty safe, but indoors can be hazardous. And increasingly, we think that the airborne route is the dominant method of spread, whereas before it was all about droplets and contact. This is a little bit complicated. I just want to draw your attention to this. When we cough or sneeze, or when we talk or sing, overwhelmingly, it's the tiny little microscopic droplets that we produce, the so-called aerosols. You can see the proportions there. And what happens to the tiny ones is they get right down into the base of the lungs when you breathe in. And that's where the defenses against infection are probably the weakest. If you get a big droplet and it hits the back of your throat, there's a thick mucous membrane there, there's antibodies on that surface, and you may well not come down with a clinical infection. But if you breathe in a load of microscopic aerosols down into your lungs, you likely will get an infection. The picture on the right is just to show you how far these small aerosol droplets can travel. This is some work by Lindsay Ma, who's an amazing scientist in the US who's done this. And you can see that the tiny ones in the red line can travel up to 100 meters in a space. So the 2-meter business of wearing a mask, unless, social distance of 2 meters, and if you're less than 2 meters, wear a mask, is not going to protect you. Wear a mask all the time indoors, doesn't matter how far away you are from people. Now, please don't get alarmed. If you breathe in one virus particle a long way away, you will not get an infection. We don't know what the dose is, but it needs to be a sizable number to get a clinical infection. So I'm just showing you this to give you an idea. You should regard other people as producing clouds of these aerosols around them in indoor spaces. And that's why social distancing is so important. If you're 2 meters or more away from somebody, most of this aerosol goes away. And if you both wear masks, you can see that the exposed contact is largely protected. But there is this leakage, and that's why things like ventilation are so important. And this is just one study I thought I would show you to demonstrate to you something called a super spreading event. And we think that a large part of the pandemic is spread in this way, that you get these events where lots and lots of people are all infected at one time. This is a study in a call center in Korea near the beginning of the pandemic in late March. The blue chairs are the people who got infected. I think there were 97 out of 216 people in the call center who got infected, all within about 3 days of each other, meaning it was almost certainly one person who had the infection who transmitted it to all these other people. Now, you could say, well, that person might have touched everybody else, but I think that's highly, highly unlikely. Almost certainly this indicates spread through the air. And the other thing that's interesting about this is that this call center was on the 11th floor of a building. People obviously used the lift to go up and down. They were touching buttons. They were in the lobby. There were 2 cases in the whole of the rest of the building. So it shows you that contact spread is actually not a very common route of spread, and certainly will not explain large outbreaks like this. They tend to happen in crowded environments where there's a lot of talking and shouting and singing produce lots more aerosols than just speaking, with poor ventilation and people not wearing masks. Okay, so moving on to the subject tonight of testing. I just thought I'd give you some basic information. You probably know a lot of this. The incubation period is after you're exposed to somebody and you get infected, your symptoms start anything from 2 to 14 days later, usually around 5 or 6 days. You are infectious to people before you actually get symptoms. So that is why people staying at home once they get sick is not going to control the virus on its own. There is asymptomatic spread, and it's important to remember that. you're infectious up to about 8 days after the onset of symptoms. There is the 10-day isolation rule because a few people are infectious for up to 10 days afterwards. So I think that makes good sense. You're most infectious just before and for a few days after you become symptomatic. You may know that the testing window has been extended to 8 days by test and trace. It was 5. Some people are saying, was that because that's because the testing services are overwhelmed? I'll leave you to make your own judgment about that. So these are the 4 pillars of testing. I think the Scottish system may be a bit different, but I think in some respects it's very similar. The important ones for us are really pillars 1 and 2. Pillar 1 is what goes on in hospitals, and pillar 2 is community testing. 3 and 4 are usually for research purposes, monitoring the pandemic, what's going on, very important work, but most of it is done through existing institutions. And as we know, that pillar 2 is the huge privatized service given over to Deloitte to organize the testing and the Lighthouse labs. The slide shows you the number of tests that are done that turn out to be positive. Some people are saying, usually the COVID denialists, that, oh, we're getting so many cases now because we're testing a whole lot more. That's true, but the rate of positivity of tests is going up all the time. And as you can see here, it's up to 3-4%. Now, this slide is about a month out of date. It's continued to go up like that. It's probably 5 or 6% now, positivity. In France, I heard a couple of days ago, it's about 15% of tests are turning out to be positive. France is in a very difficult place at the moment. So this is what the overall testing picture looks like. Certainly in England, I think Scotland is similar. There might be some differences. So you can see here, these are the pillar 1 and pillar 2 tests. The tests are taken, they go into the system. 12 billion has been given to Serco and Deloitte for the system. 300 million has been given to local authorities. This is in England. That is 40 times their expenditure. Okay. So, and what the local authorities do in terms of tracing, they do what are called complex cases, which are care homes, healthcare settings, prisons, educational settings. Whereas the contact tracing for the rest is done through Serco and Cytel. This is an important slide. Just if you just bear with me and we'll spend a couple of minutes on this. So this is information from Independent Sage. If you don't know Independent Sage, I would urge you to watch their briefings every week on a Friday at 1:30 p.m. They're very informative. And I've lifted this directly from their presentation last week. So the top line, the gray one, is the community, the local authority tracing, right? They trace 98% of their contacts. They do an amazing job. Right? This blue line here is the number of tests, the number of people that Serco and Cytel reach, the positive tests that they reach 77%. And in fact, not all the positive tests are passed to them. There's a gap in some of that. So some people drop out at that point. So they identify 77%. 66% of that 77%, they get contacts from, okay? 56%, sorry, bear with me, I've forgotten what that number refers to. Don't think it's that important. 25% of tests are returned within 24 hours, 1/4. The sooner you get a test result, the sooner you can chase up the contact. Now, what's really important here is the 77% of contacts traced and the 2/3 of positive test trace, the 2/3 of their contacts that are traced, you've got to multiply those two figures together, which gives you less than half of positive tests you trace in contacts. That is a completely dysfunctional system. You have to get at least 80% to be effective in terms of a successful system. If you don't get that high, you're not going to control the pandemic. It's not going to go down. This slide shows what happens when people are contacted. King's College showed that about 18% of people with symptoms, i.e. positive tests, actually isolate, and about 11% of their contacts isolate. It's a waste of time. I can see some of the expressions on your faces. It's a complete nonsense. You can't run a system which people don't isolate. If people don't isolate, the whole thing is just not worth it. It's a total waste of time. And the reasons for this is because people are not supported to isolate. The line on the top is the people who intend to isolate, and the line on the bottom is what actually happens. So it's not like people just don't give a damn. They want to isolate, but when you're on a 0-hours contract and you've got to put food on the table and you can't pay your rent, you can't afford to isolate. Or when the government gives you 500 quid for 2 weeks, which doesn't pay anything like your expenses, how can you be expected to isolate and not be able to meet your needs? There are other problems with the system. Data was withheld in the beginning, it's delayed. It's a completely separate structure from GPs and local services. So there are problems in relaying information. You're not getting results. It's also very punitive and coercive. They're now £1,000 fine up to £10,000 you can be fined. And data is now being passed to the police, at least it is in England. People with positive tests, they can come and coerce you to isolate. And as I've said, support for people who are isolating is completely ineffective and insufficient. So what should happen? The whole separate privatized structure needs to be dismantled and it needs to be brought into the NHS. There's no question about it. You can't just tweak it. It's a completely badly designed, dysfunctional system. It's not like there's just one or two things that can be fixed. It's like going to sea in half a boat, as somebody said. All tests need to be ordered through GPs or nurses or health professionals. If you go to the doctor or if you want a test done, you have to get a health professional to talk to you about it. What are your symptoms? And then arrange the test, tell you what the likely outcome is and what needs to happen if you test positive. At the moment, all you've got to go on is symptoms of COVID and then a result through a text message on your phone. This is not the way to provide healthcare services to people. Testing needs to be done at NHS labs. The result automatically goes into GP pathology systems. We get the results on our IT system. We know what's going on. It's logged on the patient's record. When you take the test from the patient, you talk to them about it, you explain what happens, that they might have to isolate and give their contacts, you get their consent and so on and so forth. Follow-up of patients who test positive. We could call them every day and say, how are you doing? Do you feel okay? Is somebody with you? Are you being looked after? Do you need anything? None of that happens at the moment. The data could go to the local health protection teams, run under the direction of the directors of public health, who could then keep an eye on what's going on locally to jump on any outbreaks, to put in resources in terms of contact tracing, etc. There needs to be adequate financial support. Independence Age are calling for £800 a week for people, which will allow them to isolate safely and securely with a guarantee of their job when they get back. Hotel accommodation should be provided for people in multi-generational families. you know, in lots of areas in the north of England, and I think certainly in Glasgow and the poorer parts of Edinburgh too, you know, people live in overcrowded accommodation. They can't separate from vulnerable elderly relatives. And transmission within the household is a very important route of spread. So if we made hotel accommodation where you could isolate people safely, they'd be away from the vulnerable family. Involve the local mutual aid groups, which are all over the country, who have given all their time and goodwill for free, giving out food parcels, knocking on doors. If they were involved in tracing and support, they do a fantastic job. And I just wanted to draw your attention to a project in Sheffield. The link is here. And you can, you're welcome to have these slides if you're interested. And I'll pass those on to Donnie and maybe you can circulate them. So local, as Heather was saying, is absolutely critical to success. You can't have a distant national system and get a call center from across the country and expect this to work. It just does not work. This is my last slide. I just wanted to show you. The photograph is of a couple of health workers in Cuba, Dr. Liz Caballero and her student, Susana Diaz. This is the first thing in the morning. What do they do when they get to work? They do what we call a ward round. They walk around the local community to every patient who's got COVID. They knock on the door and say, how are you doing? If they're unwell, the doctor examines them. The patient, they ask if they need any help and support. That is local healthcare embedded in the community. A shining example of it. The table on the left is a selection of countries which operate a local test, trace, isolate, and support service. Very good availability of testing and excellent mobilized local communities in contact tracing. And look at the numbers. Vietnam is a country of 93 million people, a poor country. 0.4 deaths per million. They've had 37 deaths, I think, in total. Mongolia's had no deaths at all. And then you get down to, you know, other examples here, and then you get down to us in the UK, 643 deaths per million, and the USA, 679. So I think just to end, what this shows very clearly is that when you impose an ideological, politicized, neoliberal solution on a pandemic, this is the result. You get tens of thousands of unnecessary deaths. When you have a socialized, community-based, and community-involved project which mobilizes local people, you succeed against a pandemic. It's not rocket science. You don't need masses of resources, and it can be done. And this is the direction we need to go. Thanks very much.
Thank you. That was very, very interesting. Shocking. Brilliant. Thank you so much. Okay, moving straight on to our last speaker. It's Linda Brown, who is chair of the Unite Voluntary Sector Branch, and she works in the care sector. So over to you, Linda.
Hello. Right, that's hard to follow. So thanks, Heather and Jonathan. That's been really interesting. I am a manager of a care service based in Edinburgh. It's part of a Scottish-wide company called Blackwood. I'm the Unite rep as well, and I manage the care at home service, which are the staff that go and visit mostly elderly people 4 times a day, help them with their breakfast, get them up, blah blah blah, this sort of thing. So it's from one to the other in a local area, and also a supported living service that we've just taken on, which is creating a lot of me, but anyway, a supported living service which supports people in what's called a core and cluster system, where there's a sort of office flat in the middle, and we support people in flats surrounding sometimes up to 24, a lot of them 24/7 per day, hours per day, and 7 days a week. And some of them have no family involved at all. Many of them lack capacity, etc. So there's a type of people, it's all very vulnerable people that we work with. So testing. Glad none of you were near me on Friday when we were having a big old fight with Health Protection Scotland. I swear, you just lose the will. You totally lose the will with these people. Our experience now in other parts of Scotland, Blackwood have homes. There's weekly testing going on for care workers there and so on. But I did hear today that the Aberdeen care home, the local health protection people want to treat it as a residential property, so they don't have to go and do tests there every week, which is just a joke in this situation. I don't know any company, and we don't have any regular testing of care staff, you know, particularly care at home that are in and out of so many homes so many times a day. No staff getting tested. And I'll just give you a couple of examples. Some places outside of Edinburgh, not Edinburgh, there is health protection organisations are giving advice how to protect yourself using proper hygiene standards and so on, but you know, I've not come across that here. Last week, an example for us was this lovely care worker of ours. He phoned up and said, my flatmate told me he's feeling unwell, and he's just announced that he's positive for COVID. So I had to get a test. Obviously, he didn't come to work. He just spent a 12-hour shift with someone that's so vulnerable that we are with that man 24 hours a day. And the test came back positive. So obviously, I just said to the team leader, you better make sure we get we say customer in Blackwood, not service user, because it's also a housing association. But anyway, better get our customer tested and make sure he hasn't picked it up so that we're prepared. But also obviously track and trace, we were expecting to get hold of people and so on. So we phoned Health Protection Scotland and got nowhere. So then team leader phoned track and trace people, and they've obviously got a script. So they just kept going through this script and not deviating from it. And in the end, after about, I don't know how many phone calls that poor man had to make, he got it escalated up to a manager who could actually use their own initiative to deal with stuff. But even then, what we were told we had to do was that there was no way they were going to come and test or send a test for our customer. Nah, even though he just spent 12 hours with someone who's just tested positive, not going to test him. It doesn't matter anyway, does it? Because you'll still have to go and visit him regardless. So just treat him like he's got it, and we don't have to test. They did contact the two that did a handover with the guy on the 2 days in the run up to him getting a positive test, but no one before that was tested, which caused a lot of concern. Some people, you know, I try and be a bit laid back, but some people really worry about these things. I had frantic phone calls from a couple of staff saying, you know, but all I could say was like, and Tracer said, if you weren't in contact with him Thursday, Friday, you don't need a test. You won't have got it from him if you're feeling unwell. But if you're feeling unwell, get a test. So yeah, we got nowhere with that, and it was just really frustrating. It took a lot of hours of someone's work day to sort it out on top of everything else. Another example was an irresponsible member of staff, and it's a similar thing. Irresponsible member of staff came into work and spent 4 hours with a customer, again very vulnerable, but not as vulnerable as the other one, and then said, oh, you know what, I've been feeling from the morning, I've got symptoms of COVID, and I tell you what, I'm going to go home, but I'm due to fly to Poland tomorrow anyway. You just have to laugh or else you cry. I'm due to fly to Poland tomorrow. So we said, you better get a test. Yeah. Off she went, no test. The team leader did suspect she was making it up to get away early, but anyway, how do we know? And so I said, you better get that guy a test then. Nope, we were told the phone line, oh yeah, she's got to go and get a test, the one that's just flown to Poland. But if she tests positive, then we'll consider sending a test for the customer that she just spent 4 hours with. So again, no test. And that's just repeat. It's even getting tested, I'm wondering sometimes, it's just absolutely horrendous. And it does sort of, I don't know a lot about what's happening in England, but if it's even worse than this, I dread to think. So when we do, when we have persuaded them to send us a test for someone who was displaying symptoms, they've sent the test and told non-medical care staff, these are support workers, not trained in medical procedures at all. People can change a catheter bag or a stoma, but that's it, and they're saying, we've got to do the test. We've got to carry out the test on these vulnerable people with all sorts of other medical conditions. And the staff are actually quite, but just don't want to do it in case they make a big mistake, cause a problem. And so every time, and it's only happened about 3 times that they've done this, we've refused, quite rightly, the staff on the ground have refused point blank and had to argue with the local GB practice, please send out a district nurse or come and do it, or we'll bring them up or whatever, but we're not doing it. And we have managed to get district nurses out to do it. I don't know if anyone else that works in care has had any sort of this, but I do know that some support workers are doing the test in other companies. They get sent and they just do it because they assume it's been sent to them that it's not a big deal. Maybe we should do it, but totally disagree. So that's just what we're finding is, in general, that things for us are, when it comes to the testing, we're just really surprised at where they draw the line. It's still only if you've got symptoms you can get a test. But then, one guy, and he has since died because he was so unwell. We were looking after, they said, he's so unwell, if he gets COVID with the symptoms, we're not going to come and test him because it will just kill him. That's what they said. It will kill him, and that's it. It is just really quite frightening. He didn't die of COVID. We looked after him well, but it was like, do not resuscitate. So just because it says that, does it mean that you don't even try and keep? Anyway, again, it's often people with families that aren't very involved that these work situations occur. So for staff and myself, even though I really try my best to keep on top of it and read the latest stuff from Health Protection Scotland, I feel that in general, community services like ours have been sort of left out the loop because there has been the issue with the care homes. And so we're really, I feel particularly with those with the visitors that are shielding on a regular basis and so on, there should be access to testing. Should, you know, we have PPE and so on, which by the way is, you know, tripled in price. But we do have PPE, and the council is starting to give us some money back for it, arguing, but they are. But I'd really love to get advice, and you know, when we face these situations, who is the best person to contact? Because we'll dial 111, Health Protection Scotland, the local GP, and we sort of sent round in circle. And is it an absolute that there's no point testing unless there are symptoms, which is what we keep getting told? You know, the very first case of someone that had symptoms right at the beginning, just before the lockdown, I just assumed because our people were so vulnerable that we would get a test or whatever, and they just said, no, you only get a test if you're going to be admitted to hospital. That's what it was at the beginning. You only get a test if you're going to be admitted to hospital. I goes, oh, shall I bring him to the hospital? And they said, no, if you're being admitted for something else. So it was not the greatest. But anyway, I feel like I've just done a big old moan, but this is only left over from Friday night, I tell you. Yeah, you know, I think Heather and Jonathan can maybe give me, or anyone else can give me a bit of advice about this, but it just seems to me that, you know, things really are increasing at the moment. A lot more staff are coming in with, say, or phoning in saying they've got symptoms or having tests. So, yeah, particularly, is it an absolute definite that you have to have symptoms before you'll be offered a test? I would like that question answered. But yeah, it's been very frustrating.
Thanks. That was really, really interesting, shocking as well, but very interesting. Okay, so thank you to all the speakers. We'll go straight into the second half. So if I could just remind you, if you want to speak, please use your hand by clicking on participants and raise a hand, and that way I can bring people in the order that they do it, and everybody will have a chance to speak. Okay, so I see Kathy's first, followed by Ian, and then Mike. So Kathy, if you want to just unmute yourself. Thanks.
Yeah, just to say first, thank you so much for all the speakers. That's been really helpful and interesting. I have exactly the same question as Linda on the testing of people who are asymptomatic, because a couple of things. First of all, I know that in other countries, and Jonathan, you may know more about this for us, but I know that my son just came back from China, and if they have a local outbreak, they just test everybody. They just blanket test the whole city or the whole town, and then they isolate people. And I don't know whether that's, I mean, it seems that it works for them. Is it a legitimate thing to aim for? But also, should we be testing people who are asymptomatic? And a linked question to that is, I work in workplace health and safety, and we are getting more and more people asking, okay, I've got a colleague at work who's tested positive. What am I supposed to do? Now, when we ask this question, we're told Test and Trace will get in touch with the employer, or if there's a need to, or they'll get in touch with any individual colleagues that have been identified as being at risk. But people want to do something. If they know colleagues have been tested and have been positive, they want to go and get a test, or they want to know what's happening. And it's a real dilemma. We had one case where a guy knew that a colleague had tested positive, said to his employer he wanted to go to get a test. The employer said if he left work, he would discipline him. The guy went and got a test anyway, and it was positive. So I suppose it's both questions are linked about the asymptomatic testing, but also about the workplace situation. Thank you.
Thanks, Kathy. Before I bring Ian in, just to say that we'll bring the speakers back in at the end, so they'll be able to hopefully answer some of these questions. So there'll be time for that at the end. So please do ask away. And the second thing is, Jonathan offered to send his slides. So if you don't get emails from Des directly, if you leave your email address in the chat, I can pick it up at the end and make sure you get those slides. But if you get it from Des, you don't need to do that, because I'll send Des the slides. He'll be able to distribute it to the usual people, if that's okay. So Ian's next, then Mike, followed by Des. So Ian next, if you could unmute yourself, please. Ian. Yeah.
Thanks, Donny, and thanks to the three fantastic speakers as well. Can I just say, Linda, I feel your frustration, because I'm the Unison Health and Safety Officer for the Council. And since May, I feel as if I've just been hitting a brick wall for a great part of the time. We've had irresponsible people coming on sites into depots who have been symptomatic, have been around the depots, have been in vehicles, and then admitted that they have had symptoms and been sent home. One of the three was actually tested positive, the other two wasn't. We've had issues around health and social care staff. We've been asking for the risk assessment since May. We were told that they were held in a command centre in National Ainslie Hospital by the IGB. That turned out not to be true, and like yourselves, we had staff in care homes and in client homes that were going from anything from 8 to 13 different homes per day. They had a lack of PPE, that didn't have any risk assessments in place, and I ended up having to call the HSE in. And I have to say, my experience of the HSE is that they have been completely ineffective. I ended up writing to them saying, it's pointless you actually assisting us, because all you're doing is actually charging the council for letters, emails and telephone calls, but you're not actually serving notices or giving them positive advice. Most recently, we've had a massive increase in infection rates in schools. It took me 10 days to get the figures for that. They come out every Friday now, and 2 weeks ago, we had 32 positive cases. Last Friday, that jumped to 97. So you can see that in higher education, schools, early years and the universities, there is an ongoing, highly risky situation there. We're now talking about opening community centres and libraries as well, and doing youth work. And I've made our point of view from Edinburgh Unison very clear to the senior managers. But with regards to Health Protection Scotland, this is the latest crisis that they've got, because a couple of weeks ago, I raised a question at a partnership at work meeting with the senior directors and the chief executive. Senior member of Health and Social Care was there, could not tell me what the correct procedure was for COVID, for positive cases in the workplace. I then asked him about testing, and he turned around and says, you will only get a result if you're positive. And Jonathan, you were saying there that you could be positive for days before actually becoming symptomatic. So that statement is completely false and completely flawed. And we have a major issue because a GMB steward actually got into me 2 weeks ago to say she had had 3 tests and hadn't had a result, and had a symptomatic client in the care home who turned out to be positive, and it took 2 days to get a result back. That senior manager in Health and Social Care has now told me that you will only get tested or get a result if you're positive. We've had cases where individual members of staff have came back and the test has been inconclusive. So, you know, the system in Scotland is fundamentally flawed, and That's in a local authority that's got 14,500 members of staff. God knows what it's like elsewhere in Scotland. Thanks, Donny.
Thanks, thanks, Ian. Okay, so Mike's next, and then Des. Yeah.
Yeah, thanks everybody. Really important that this meeting's happened, and I'm very grateful for it, and to the speakers. It seems to me that one of the most tragic things about this complete mess we're in is that people like Ian and Linda and Heather, who are struggling at the front of these things, and of course workers in the hospital services, have had the most awful experience of trying to do their job in despite all this craziness, particularly around testing. But I'm glad Jonathan's mentioned the independent sage, because I think it is it's one of the two extraordinary things, I think, about this epidemic in the UK. And one of them is that in parallel with corrupted scientific advice by a handful of scientists who've been co-opted by the government, in parallel with that, throughout the epidemic, we've had this independent sage producing extraordinarily high quality work. And most recently, I've just put it in the chat box, I think Jonathan referred to it, they produced a report saying what should happen with what they call the find, test, trace, isolate and support system. So they talk about FTTIS. But, you know, we have a model. It's extraordinary that in parallel with the botching up by government, we've got this model. And the second extraordinary thing is that the things we're talking about are where public health, way before the NHS, 150 years or so ago, everything we're talking about localized tracing, even street ward rounds and well-trained people, and support and encouragement above all for people, for cases or for people who were contacts. All of that was piloted in Glasgow with cholera epidemics 150 years ago. So here we are at the seat of what was the best public health service in the world, you know, in this extraordinary mess. And I think, as Jonathan's suggested, I think what this shows is the power of a neoliberal system which can corrupt this. And the main way that has happened, I think, is that it's hollowed out, as it's hollowed out through austerity, but before that, it's hollowed out community services, of which the public health service, the local public health service, was one of the most important. Thanks.
If you unmute yourself, Des, yeah?
Yep.
Go ahead, yeah.
I really got a question to address to Jonathan. I mean, I've been following the debate today about sort of argument between Manchester, Andy Burnham and the Prime Minister. And Andy Burnham is talking about how they need more money for supports for workers and they need this and that. But what I was struck by when I heard what Jonathan was saying and his programme, what should be done, that wasn't part of that national debate. Although this debate is going on nationally, it's involving senior politicians, Green politicians, Liberal politicians, and Labour politicians like Keir Starmer. They're not advocating his programme. They don't even seem to be aware that the programme exists. Well, Andy Burnham when he's talking about what's needed in Manchester, he's not aware of. He doesn't, what he's saying, realise that the system, as you describe it, is dysfunctional. He's not saying that to the public or the governments. And so, and if we get to Edinburgh, I mean, the city council wouldn't say, has never said that the system is dysfunctional. It's not in its current mode of thinking. Neither is the Edinburgh Integration Joint Board, which integrates social care between the health service and the city council. It's not talking about dysfunctionality. It talks about private care homes as being partners. It talks about the private sector as being partners. they fully bought into, if you like, this neoliberal model of things. So my real question to you is, how do we actually change things? I have no answer to that down in London or Southern England, but you would think that we would be better able to change things in Scotland. But even the unions in Scotland, never mind the UK, aren't actually saying that the system is dysfunctional or actually publicising or seeking public support for your plan. Thanks.
Thanks, Des. Rakia is next. If you unmute, Rakia.
Thank you very much for having me. I just want to say thank you to the incredible presenters, the three of you, Heather, Jonathan, and Linda, sharing their experience and the difficulties we're facing. For me, I think the grassroots of the problem is when you have leadership that is corrupt. Somebody might say, why do you say that? We know the truth. Issue around TB, HIV, and other disease that uses the model of contact tracing. I remember 20 years ago when I went into Edinburgh University to study public health, I thought it was something I was going to use back in my motherland, which is Nigeria. United Kingdom is one of the countries that people envy and look up to in terms of the healthcare system we have. A system where the leader doesn't lead by saying the truth. The leader doesn't listen to the professionals. We have Boris Johnson coming to tell us, oh, we are listening to the scientists. That is not the case. Any student in the public health department today, any medical student knows the modeling of contact tracing and how we can avoid it. I think when the evidence keep on emerging that people from Black and ethnic minority or those who are likely to be 4 times to die before other people, I think the government took it lightly, and they're still taking it lightly. Jonathan, you mentioned things like people who are on 0 contract hours will be the first person to think about their income, what they're going to get before, even if they know they're unwell, they want to go to work because they want to put food on the table. They want to send money home to their family. They want to do things for the people they support. The government, they are aware of it. We need to come to different forms in challenging everywhere you work, because for me, working in an organization of 30,000 staff, NHS Lothian, we have a voice. We need to put our foot there. We need to professionally challenge it. Even if you are not in position of making that challenge, I think you're not comfortable with it. We need to find a way. It's a shame for us to see that data. And that's just one a bit of data globally that keeps on coming out. So for me, what I want to say is that there's a lot to be done. If we shouldn't be looking at other countries like America, we should be talking about what do we do for our people? Because people are dying. People are getting infected and they're not following the rules, the methodology. Nobody even knows the modeling of this disease. We are not even doing the basic contact tracing the way it should be done. That's what everybody should try and get involved. Making sure that the communication of what should be done is cascaded down to the grassroots. Putting it in the simple language or graphic method that people will understand so that they can challenge the system. The people, those of us here today, we have no problem. There are people out there, the asylum seekers, the low-paid workers, the people whose English is not, language is not, their first language is not English, and people who even if they're English, they're in a very poor situation. They don't even know what is expected of them. Not just the mask, not just the washing of hands. There's a lot to that. So I think for me, let's keep challenging. Let's find out what's the right thing to do so that history will forgive us that we are not just talking the talking, we are making actions, and the action is challenge the system. Thank you.
Thank you, Rakia. I'll bring in Penny next, just to say to people, that was really good. Just to say to people, we'll be finishing at 8 o'clock, so I'll be hoping to bring the speakers back in a few minutes, 3 or 4 or 5 minutes. So if you've got any last questions, if you pop those in, I'm just going to turn off my video so that Penny can speak without our system crashing. So.
Yeah, thanks. We've got a very unstable connection here. Yeah, what absolutely fantastic set of speakers. It's absolutely brilliant. And I think people are saying, you know, it goes beyond the medical information. You know, it's always social. As Des said, you know, they have imbibed a neoliberal agenda, and that is not going to do it. You know, those numbers, Jonathan, they were stunning, and I hope you will share those slides, because when you see the difference between people who are, you know, not coming at it from a perspective of sharing all the billions out with their friends so that they track and trace to nowhere, you know, circle, we know what the outsourcing and everything is about. So I'm pretty stunned, because this is a fantastic meeting, and was at a brilliant meeting at the Scottish launch yesterday of the people before profit. And our
Penny, you're muted. You've muted yourself.
no, I don't know why.
Yeah,
It's a very, very unstable thing. So Kathy was speaking yesterday at the meeting. Claire was co-hosting it, and a lot of what people have been saying about, you know, as Jonathan really pointed out, and others, the other speakers as well, about, yeah, we have to have public ownership of services and end the outsourcing of testing and tracking, because that's not working. It's disgusting corruption. And it's absolutely useless. I'm trying not to swear, because it's really, people's lives are at risk here, and it's not working. So practically, I would like to make a suggestion, and that is that I don't know if Donny, if you can share the headline things from the people before profit, but guaranteeing safe workplaces, as Kathy was saying, that is so shocking that people are being threatened with disciplinary action if they get a test and they are positive. Whether they were positive or not, they should never be threatened with it. Extending the furlough scheme in Germany, they've had it for furloughs for another year. It's no big deal. It's being treated as though it's impossible. All the money's going to business, big business mainly, and not to ordinary people. How, as Jonathan said, how can people isolate and lose their job? You know, they're not going to do that. So, you know, I'm just wondering. And also, I mean, I think Pete Cannell put something down about the other kind of organisations we need. But I think one of the items in People Before Profit is for an immediate massive programme for green investment. So real social security. And I just wondered if we as a meeting today could support those items. I know it's not something for the Trades Council has to take its own position. So I'm not trying to sort of say this would be from the Trades Council, because it's not. I mean, obviously, that would be another discussion and another decision on another day. But would it be all right if we put those forward to the Trades Council? Because I think it would have a lot of weight if we did. That's me.
Thank you. Thanks very much. Okay, so there's a proposal there. I haven't got to hand the People Before Profit things, but I'll look for it. But anyway, Hilary was next, and then Ian, and then Carmen. I'll see if I can find it. Okay, Hilary next.
Hi, I'd like to ask Heather about something she said about the NHS regional testing posts being set up. I mean, this sounds kind of optimistic. Is it? Was it done by the Scottish Government in response to the chaos in testing? Is it going to increase? Is this the start of transferring testing in Scotland from private to public hands? Perhaps you could say a bit more, Heather. Thanks.
Hi, Hilary. Yeah, it has come out of the chaos that has been the Lighthouse Laboratories and the need to up the demand for sample testing, especially within NHS and the care sector. And people coming into hospital now must have a negative result before any treatment is provided within hospitals for elective surgery and things like that. So there is a greater demand for testing, and the hubs have been granted, shall we say, by the Scottish Government a purse of money that seems to be fully lined at the moment to allow them to get the machinery in, the staff employed, the training done, and the buildings, because 2 out of the 3 so far are taking over old BTS laboratories. So there is an upgrade happening. The one in the East Coast is being run out of Lauriston buildings, and the BTS labs in Lauriston buildings will become a regional hub for the East Coast. And Gartnavel is the hospital, BTS labs will run the West Coast. I'm not 100% sure about the North, but I think there was talk that there is a previous BTS building that is lay dormant that the NHS will take over there as well. And it will greatly increase the NHS capacity.
Thank you, Heather. Right, moving on. Ian and Carmen, those will need to be the last speakers, I'm afraid, because I want to bring the speakers back at the end, if that's okay. So Ian and then Carmen.
Thanks, Donny. Very quickly, I'm glad that Rakia picked up on the BAME issues, because Edinburgh City Council did implement some other individual risk assessments and other adjustments for BAME, but it took Unison to actually get one of your colleagues who was at a meeting and is an MSP to raise it in the Scottish Parliament before that action was taken. And secondly, I wanted to say as well, maybe Jonathan or Linda or Heather can give me their opinion on this. The Employment Rights Act, Section 44 and 100, has only been used once in the whole lockdown, and that was by Unison, and it was actually my decision to recommend it to a home care worker whose client wasn't socially distancing. Section 44 clearly states that any employee can withdraw from an environment of work that they consider to be hazardous to their health without any detriment. Unfortunately, the management from Health and Social Care didn't take any interest in that. That health worker, after 20 years service, ended up going off long-term sick for 3 months with work-related stress, had 2 what can only be described as Mickey Mouse charges brought against her, and then after 3 months went through 2 investigations, which I represented her, and again the ERA wasn't taking any action of when I raised that, and after 3 months the outcome was no action taken, lack of evidence, and that poor woman is still off. And that's the way that low-paid, predominantly care workers are being treated, not just in the private sector, but in the public sector as well. We now say, street cleaners, refuse collectors, cleaners, home care workers, they've all been identified as key workers now, but they have been for years, and they should actually be recognised as professionals. Thanks, Tony.
Okay, so Carmen will be the last person, and then we'll bring the speakers back. Yeah.
Yeah, I mean, hello everybody. It's just kind of a comment and a question as well. When Linda was talking about that you just get tested when you get symptoms. My first reaction was just phone and say that you have symptoms. I cannot taste my coffee. I said, that was kind of the first reaction. But obviously we shouldn't be put in that position. And my question or comment is if key workers, we are expected to go out and work, like a kind of people in the NHS, people in social care, teachers. I think whether it would be possible from unions to push on regular weekly tests for staff, and whether, and that's kind of a question to Heather, you think that would be something that the testing program in Scotland would be able to cope with? Or we would be asking for something that is unmanageable. Would that be possible? Do you think that the system as it is would manage for all these essential key workers to be regularly tested in order to keep us all safe if they wanted us to come back to work or to keep working in safe conditions.
Thanks, Carmen. Okay, thanks. Right, I'll bring the speakers back, but Penny wanted to raise this thing which I have shared. Can people see that? I managed to locate it. This is the thing. Aberdeen, Glasgow, Dundee trades councils are all backing this, and so I think what Penny was suggesting was that this be taken to the next trades council meeting for consideration. See if we want to join the other trades councils in doing that. So that's it. I won't leave it up long because we have to finish the meeting, and I want to bring the speakers back. So that's it. Okay, so if that's all right with people, I will just bring the speakers back in, unless there's anybody got strong objection to us taking that along to the Trades Council meeting, which I think it'll be the second week in November from this meeting. Okay, right. Okay, so sorry it was so short. Shall I have the speakers in reverse order, if that's okay? That's the usual way. So Linda, would you be okay to come back on anything that people raise? Final thoughts? Thanks.
Yeah, just very briefly, thanks for all the supportive comments and so on. Glad I didn't depress you too much with my whinging. Carmen's point about saying, yes, we're positive. Yeah, staff can do that, but it's more difficult if we do that on behalf of a vulnerable thing. Yeah, I know. Plenty of people do that, Carmen, come on. But you feel bad that you're forced to do that. I'm still waiting for me. I know Scotland says symptoms, but because I saw the comment that Heather put in, but yeah, if that's the absolute, then it's almost like, going from what Jonathan said, it's a bit of a waste, isn't it? Yeah, in social care, Ian mentioned about someone being disciplined because their client wouldn't socially distance, felt they were unsafe. Yeah. Most of the work, a lot of the hours that care workers put in it's not possible to socially distance. Obviously if there's a choice and people aren't sticking to that, as a manager, I would back someone 100%, if the person can understand what they're doing. But yeah, in where I work, that's not an option. The PP is so important, and really just on the black ethnic minority stuff, I spent quite a bit of time drawing up a specific risk assessment for staff that were ethnic minority, because obviously, well, not just myself, but because I don't do a lot of frontline work, but there is a very diverse workforce we have. So, but I found that a lot of the team leaders just were not keen to do it, not keen to carry out the questionnaire. There are completely different levels of what is obese for South Asian people compared to white Westerners, and there's, and all these factors, that adds to the possibility that if you get COVID, it's more risky for you. So, but yeah, I found that. I don't know if anyone else has found that in their workplaces, but that was a bit disappointing, because I did find that a lot of the team leaders just weren't keen to do it, and I didn't have time to keep pushing it. But anyway, thank you very much for letting me speak tonight. I don't have anything else to say.
Thanks. So Jonathan's next. Apologies to Rakia. I'm just going through the speakers first, but I'll keep the meeting open and there'll be a chance to chat at the end. I know Rakia wants to come in again. But so Jonathan's next, if that's possible, please. Just to sum up.
Thanks very much, guys. And thanks for the excellent contributions, everybody. It's been really interesting hearing your experiences, and upsetting as well to hear what you, Linda, and Ian have had to put up with at work. I mean, I think it's awful that you just feel so unsupported. And I would urge you to contact your unions. I mean, in Unite, we're trying to develop some educational materials for health and safety reps so that people can be better informed, because you know what it's like. Management always get away with murder because you don't really know what's right and what's wrong. And they always, of course, choose the option that suits the business rather than defends and protects the interests of workers. Just a comment on the issue of tackling the pandemic. Des, you raised the issue of Andy Burnham in Manchester, and you know, why aren't we saying more about how dysfunctional the system is? The problem is that the whole pandemic has become so highly politicized that you can't see the wood for the trees. I mean, what Burnham is doing is he's holding out against level 3 or the tier 3 because they're not getting enough resources in Manchester, which I agree with. But when you have the chief medical officer standing next to the prime minister saying that even tier 3 is not going to work, I mean, it's a complete nonsense. You know, if you want to know what we need to do, I would urge you to look at that Independent Sage document that Mike posted in the chat, because that sets out the emergency plan. That is a coherent plan about how to get out of the hole that we're in now. But in a broader picture, this is fundamentally a political problem. COVID-19 is not only shines a bright light on all the inequalities and injustices of the system that we live in, it's actually an accelerator of all those dreadful negative consequences for working class and Black and Asian people in our society. Who's dying in this pandemic? It's not rich white people in the home counties. It's working class people, it's Black and Asian people, the damn essential workers that keep this country going. These are the people who are putting their lives on the line. If you live in a posh house in Kensington, you get your deliveries through Ocado. You don't have to even go to the supermarket and buy your own food. And they have the cheek to offer 500 quid to people to isolate for 2 weeks for their whole family. This is a political problem. So I would urge you all to challenge the whole basis of it. And in fact, the test and trace privatized system has done so badly, it actually offers us an opportunity. What I say on the phone to all the patients I speak to when I'm doing my 111 calls, whenever we start talking about testing, I apologize and I say, I'm sorry, but the privatized test and trace has failed. I don't use the word NHS test and trace, as somebody quite rightly made the point. So I'm at the same time as I'm doing my job, I'm reinforcing the issue that this is a privatized service. And in fact, as I say, it offers us an opportunity to show up how bad it is when we are offered the false choice of private is better. How long have we heard that from the government? Private is better. We know what that leads to. It leads to worse services, less access, and job cuts. We know this. And I think test and trace has shown that so clearly. So hammer away at that point in the discussions that you have with your friends and your unions and your workplaces and so on. Then quickly, I'll finish. I'm conscious of time. The issue of testing for symptoms only. Unfortunately, this is what the government has said. You can only get a test if you have symptoms, not only symptoms, but the 3, if you like, commonest symptoms, which are high fever, cough, and loss of sense of taste and smell. But we know clinically as doctors that half of children, more than half of children, have not one single one of those 3, and they test positive. And in terms of adults, 80% of adults have at least one, but there are a good proportion who have none as well. And if you just go on those 3 symptoms, you will miss a lot of people. But the problem is, you guys on the shop floor in your workplaces as care workers and as union reps and so on, you haven't got the authority to challenge that when the people on the end of the phone are saying, no, you haven't got symptoms. So what I would say is raise that with your regional union reps, raise it with management and say, we need to be safe at work. We need to get tested so that we can go back to work and be safe. And that story you told, Linda, is horrifying. If you're with somebody for 12 hours who is infected and they're not going to test you as a care worker, it's outrageous. Anyway, I'll stop there. Thanks very much.
Thank you very much, Jonathan. Okay, and finally on to Heather. So if you could wrap it up, I'll keep the meeting going afterwards if people want to chat. Everybody can unmute, but Heather will be our last speaker. Thanks, Heather.
Thanks, Jonathan. I think you summed up really everything there in your closing remarks. And one other thing about the testing is the sample taking. There is a lot of negative results because samples just aren't taken properly. These postal tests, people walking out and you watch them on the news report saying, oh, I walked out of this testing centre, it was all right, it was easy done. It's not easy. Let me tell you, if you have a COVID test, if your nose doesn't nearly bleed and you physically are not choking at the swab, then you haven't done it properly. You haven't done it properly. And anybody that walks out a test centre saying, oh, that was easy, it was straightforward, or does it themselves and doesn't have the right symptoms, the test will not come back with the right result. It will be incomplete, or it will be negative at most. So that is the end of my little spiel on testing, I think. And thank you for allowing me to speak tonight.
Thank you, Heather. That was great. And thanks to all the speakers. Just before we wrap up, yeah, and some silent applause, absolutely. Just before we wrap up, next week's meeting is and we've got another excellent panel of speakers. It's on COVID and the disabled. So that's next week. So, and there'll be notices going out for that. Ian Mullen's been drawing together the panel of speakers, and it's going to be a very good one as well. So keep an eye out for that. And what I'm going to do now is I'm going to formally close the meeting, but I'll leave it open. And if anybody wants to unmute themselves and just chat to whoever is in the room, feel free. But thank you very much for coming along and hope to see you next week. Thanks a lot.